everyone and a very warm welcome on behalf of Delhi Gynae Forum. We are pleased to have a great speaker with us, Dr. Veena Shinde. Ma'am is a senior consultant in obstetrics and gynecology from Mumbai, and she's a postgraduate in ART from University of Warwick in UK, and she's a director of Spine and Test Tube Baby Center in Mumbai. And ma'am is going to deliberate on the topic of fibroids, novel management methods. And we have Dr. Sharda Jain ma'am with us. Ma'am is Secretary General Delhi Gynae Forum and Director of Life Care. Ma'am is life and soul behind the Delhi Gynae Forum. Thank you, ma'am. And we have experts with us. We have Dr. Jyoti Bhaskar. Ma'am is President of East Delhi Gynae Forum. She's a senior consultant in obstetrics and gynecology and associated with Apollo Cradle, Indrapuram. Ma'am will be joining us shortly. Dr. Vandana Gupta ma'am, she is the Vice President of East Delhi Gynae Forum and is a senior consultant of obstetrics and gynecology and associated with Max Hospitals, Paparganj. Dr. Surjit Kapoor ma'am is an executive member of East Delhi Gynae Forum. She is a senior consultant and the director of Kapoor Hospital in East Delhi. Dr. Shakuntala Kumar ma'am is a MD FICOG and she is a senior consultant obstetrics and gynecology from New Life Hospital and Fortis Hospital in Delhi. We have Dr. Jyoti Malik, senior consultant OBGYN and an ART specialist, and is the director of a JJ Institute of Medical Sciences at Bahadurgarh in Haryana. I'm his director and chief consultant of Roots IVF and Fertility Institute, which is a world-class advanced ART facility. Dr. Seema Sehgal ma'am is the director in charge and head of IVF department and My Baby IVF Center at MKW Hospital. We have Dr. Chandralata with us. She's a senior practitioner in East Delhi. And Dr. Anita Agrawal ma'am, she's a senior consultant associate with Max Paparganj. And Dr. Nirupma Goyal ma'am, senior consultant and a director of Goyal Hospital, East Delhi. And Dr. Asha Sahai with us, senior consultant of obstetrics and gynecology from East Delhi. Thank you, ma'am. Over to you, ma'am, Dr. Veena Shinde ma'am, for the talk.
Thank you for your kind introduction. Very interesting topic, uterine fibroids.
Indeed, ma'am.
Fibroids, myoma, leiomyoma, fibromyoma. Uterine fibroids are the most common benign tumors in women of reproductive age and may be asymptomatic, but they are also a major source of clinical morbidity. Fibroids originate from the smooth muscle of the myometrium and consist of large amounts of extracellular matrix that contain collagen, fibronectin, and proteoglycan. Depending on the study, the prevalence of fibroids ranges from 4.5 to 68.6% of women of reproductive age. In India, the prevalence is 37.65 in rural and 24% in the urban population. Etiology of uterine fibroids. Estrogen, it has been implicated in growths of myomas. Studies show that myomas contain estrogen receptors in higher concentration than surrounding myometrium. Myomas may increase in size with estrogen therapy and in pregnancy. They are not detectable before puberty and they regress after menopause. Progesterone, increase mitotic activity and reduce apoptosis in size. Genetic predisposition. Fibroids are monoclonal and about 40% have chromosomal abnormalities that include translocations between chromosomes 12 and 14. Deletions of chromosome 60% may have yet undetected mutations. Etiology of fibroids, growth factors. Major growth factors in uterine fibroids include TGF-beta, that is transforming growth factor beta, epidermal growth factor, platelet-derived growth factor, vascular endothelial growth factor, and insulin growth factor. TGF-beta3 are the key regulators of cell growth, differentiation, inflammation, and apoptosis. COMT, catechol-O-methyl transferase, an enzyme that is recently linked to the pathogenesis of fibroids. COMT is highly expressed in uterine fibroid compared with normal myometrium. WNT signaling pathway. The WNT pathway could mediate molecular and cellular mechanisms involved in tumor initiation. WNT acts as a paracrine signal from estrogen progesterone receptor-rich mature cells to activate the canonical beta-catenin pathway in fibroid stem cells. Development and growth of uterine fibroids simplified. Importance of mutation-derived transformation. Chronic inflammation and impaired DNA repair. There is transformation of a myometrial stem cell to a uterine fibroid stem cell with proliferation of extracellular matrix formation under the influence of growth factors and formation of uterine fibroids. The risk factors are early menarche, below 10 years, increasing age, family history, nulliparity, and high basal metabolic index. Symptoms could be urinary frequency and urgency, pelvic pressure, constipation, abnormal uterine bleeding, usually excessive menstrual bleeding, and low backache. Leiomyoma subclassification system. Submucosal could be pedunculated intracavitary, less than 50% are intramural, more than 50% intramural. Others, contacts endometrium 100% intramural, subserosal more than 50% intramural, subserosal less than 50% intramural, subserosal pedunculated, others specify cervical or parasitic. Hybrid leiomyomas impact both endometrium and serosa. 2 to 5 submucosal and subserosal, each with less than half the diameter in the endometrial and peritoneal cavities respectively. The ESGE classification, type 0, entirely within endometrial cavity, no myometrial extension, pedunculated. Type 1, less than 50% myometrial extension, sessile, less than 90-degree angle of myoma surface to uterine wall. Type 2, more than 50% myometrial extension, sessile, more than or equal to 90-degree angle of myoma surface to uterine wall. The FIGO and ESG systems should be used for the classification of fibroids, and pre-surgical classification should be considered for selected clinical situations. Types of uterine fibroids: intramural fibroid 75%, submucosal fibroids 15%, pedunculated subserosal fibroids 10%, cervical fibroid 1 to 2%, pedunculated submucosal fibroids, polyps. Pathophysiology: role of estrogen and progesterone hormones and their receptors. In progesterone may stimulate the mitotic activity and proliferation of leiomyoma, upregulates PCNA expression in the leiomyoma cell in secretory phase. PCNA labeling index in leiomyoma is higher than adjacent myometrium. Beta cell lymphoma 2 is abundant in the leiomyoma cell in secretory phase. Beta cell lymphoma 2 is shown to prolong cell survival by preventing apoptotic cell death. Progesterone may act as a growth promoting factor in regulating leiomyoma growth through upregulating beta cell 2 protein. Catechol O-methyl transferase, an ubiquitous enzyme that has been recently linked to the pathogenesis. COMT levels are elevated in uterine fibroids. 2,4-hydroxyestradiol has anti-estrogen activity, but under the influence of COMT, the estrogen activity increases and causes uterine fibroids. TGF-beta3 are the key regulations of cell growth, differentiation, inflammation, and apoptosis. TGF-beta3 is elevated 3 to 5-fold in fibroid compared with myometrium. ECM overproduction by inducing the expression of collagen, fibronectin, and proteoglycan, key regulator of cell growth and differentiation, causes inflammation and apoptosis. Uterine fibroids: increased number and expression, progesterone and estrogen receptors, increased COMT expression, increased TGF-beta3. Need to take care of all these three major etiological factors. Diagnosis: history, physical examination, laboratory testing, imaging and endoscopy. Pelvic ultrasound is step 1. Step 2, evaluate the uterine cavity in patients with suspected submucous fibroids or those desiring fertility. Saline infusion sonography, hysteroscopy. Step 3, additional imaging as necessary when complex intervention is planned or malignant disease is suspected, MRI. The algorithm is: uterine fibroids are diagnosed. They may be asymptomatic or symptomatic. If they are asymptomatic, clinical surveillance is done. If they are symptomatic, premenopause and postmenopause. Premenopause, patient wishes to preserve fertility. Patient wishes to preserve the uterus. Patient does not wish to preserve the fertility or uterus. If patient wishes to preserve the fertility, medical therapy, non-steroidal anti-inflammatory drugs, oral contraceptives, LNG releasing intrauterine system, tranexamic acid, GnRH releasing hormones, selective progesterone receptor modulators, surgical therapy, myomectomy. Patient wishes to preserve the uterus, medical therapy, LNG releasing IUD, gonadotropin releasing hormone agonist, selective progesterone receptor modulator, surgical therapy will be uterine artery embolization, MRI guided focused ultrasound surgery, or myomectomy. Patient does not wish to preserve fertility or uterus, surgical therapy, uterine artery embolization, MRI guided focused ultrasound surgery, myomectomy, hysterectomy with or without bilateral salpingo-oophorectomy. Post-menopause, possible investigations, endometrial biopsy and imaging, hysterectomy with or without bilateral salpingo-oophorectomy or myomectomy. Fibroid diagnosed by physical examination in USG, abdomen, pelvic, sonography, asymptomatic, symptomatic. Diagnosed incidentally, uterus is less than 14 weeks in size, expectant management, periodic evaluation. Uterus is less than 14 weeks in size, discuss options with woman, surgical management, hysterectomy or myomectomy. Symptomatic, medical management with ulipristal, GnRH if indicated, failure of medical management, surgical management, either hysterectomy or myomectomy. Infertility, submucous cavity distorting myomas, myomectomy is done. Other types of fibroid, expectant management can be done. Treatment of uterine fibroid should be tailored to the size and location of the tumors, the patient's age, symptoms, desire to maintain fertility, and access to treatment and the physician's experience. Treatment, medical management, hormonal, non-hormonal, alternative surgical intervention, surgical, myomectomy or hysterectomy. GnRH hormones agonists, combined oral contraceptives, androgens, LNG releasing IUD, selective progesterone receptor modulators like ulipristal, mifepristone, asuprasnil, and progestins. Limitations of medical treatment, GnRH agonists, leuprolide, triptorelin are painful injections and there is low compliance. Slightly increase in BMI and body weight, risk of recurrence, expensive, not safe and contraindicated in adolescents. Also, there is an incidence of calcium deficiency. Combined oral contraceptives not safe for long-term use can increase the size of the myoma. Androgens like danazol cause acne, hirsutism, it's associated with liver toxicity and musculoskeletal pain. Surgery may still be required in spite of the medical management. Limitations with medical treatment, selective progesterone receptor modulators, serious acute drug-induced liver injury, NSAIDs, lack of supportive evidence from clinical trials, GI side effects and risk of gastric problems, antifibrinolytic drugs like tranexamic acid used to treat menorrhagia and dysmenorrhea can increase the size of the myoma. So the surgical alternatives are hysterectomy, laparoscopic hysterectomy, myomectomy, hysteroscopic myomectomy, uterine artery embolization, MRI guided focused ultrasound surgery. The risk of anesthesia and surgery, bleeding and trauma, focused ultrasound surgery, procedure does not produce tissue for diagnosis and can lead to delayed diagnosis of and suboptimal treatment in leiomyosarcoma. Uterine artery embolization, diagnostic delay of 13 to 15 months, pain, fibroid recurrence, potential ovarian failure, and abnormal placental development. Risk of hysteroscopic resection, risk of development of uterine sarcomas after resection of endometrium or fibroids is estimated at 0.13%. Risk of laparoscopic myomectomy, there have been recent concerns about disseminating tumor fragments and upstaging of disease. Hysterectomy has morbidity and risk of surgical long-term. Selective progesterone modulator, ulipristal acetate, has serious acute drug liver toxicity, liver transplant and death has been seen. The European Medicine Agency, Science, Medicine, Health, Pharmacovigilance Risk Assessment Committee recommends revoking marketing authorization of ulipristal. The current therapeutical strategies are not decisive and often give side effects. Acute liver failure associated with ulipristal, a case report. A 54-year-old woman began ulipristal 5 mg daily for fibroid-associated bleeding. Basal liver function tests were normal. They were performed once monthly. In the second month, LFT showed alanine aminotransferase 321 and aspartate aminotransferase 182. Treatment was stopped, presented to emergency department 5 weeks later with nausea and fatigue without fever or abdominal pain. Physical examination normal except for jaundice. Laboratory test total leukocyte count was 6,000. Neutrophils 63%, lymphocytes 21%, and eosinophils 0.8%. LFT, ALT 189, AST 1648, alkaline phosphatase 105, GGT 415, total bilirubin 8.7. Patient was hospitalized, transferred to another hospital 48 hours later for worsening LFTs, needed N-acetylcysteine for 7 days. Transjugular liver biopsy on day 2 of admission showed severe hepatitis, portal and periportal inflammatory infiltrates with polymorphonuclear and mononuclear cells, extensive diffuse nodular necrosis, prominent Kupffer cells, numerous Councilman bodies, no cytomegalovirus inclusions. Fibrosis, patient went to develop grade 3 liver encephalopathy, received liver transplant 11 days after first admission, favorable post-operative course, normal LFTs, discharged after 12 days, not required for fibroids. Concepts for the future. Current concepts on the use of natural anti-uterine fibroid compounds. Hormonal compounds like GnRH analogs, elagolix, linzagolix, relugolix, luprolin, goserelin, progestogens including LNG IUDs, combined oral contraceptive pills. The non-hormonal products like triptylgerium, Wilfordi, epigalactin, galalate, 45%, and vitamin D. Additional symptomatic treatment with NSAIDs and antifibrinolytics. A new therapy, non-hormonal for intrauterine fibroids, taking care of all etiological factors of uterine fibroid, acts on both progesterone as well as estrogen receptors, hits the new target of fibroid, that is catechol O-methyl transferase and transforming growth factor. Triptylgerium, Wilfordi, epigalactin, galalate, and vitamin D3. Triptylgerium wilfordi is a product of the vine plant. The root of TWHF is the main official part used in medicinal applications, although its stem and leaf also have the same chemical composition and function as those of the main ingredient. Clinical application of Triptylgerium wilfordi for treatment of gynecological diseases. It's a Chinese article. Extract of Triptylgerium wilfordi has obvious effects on anti-inflammation, anti-tumor, anti-fertility, immunoregulation, and it is broadly applied in various clinical departments. Referred to the gynecological diseases, clinical therapeutic trials on TW on endometriosis, leiomyomutri, dysfunctional uterine bleeding, and some tumors of women have been carried out, and it can be proved an effective new drug and can be used for treatment of gynecological diseases. Triptylgerium wilfordi inhibits the expression of estrogen-progesterone receptors and thus reduces the estrogen and progesterone biological effects in fibroid tissue. It decreases anti-apoptotic factors BC1-2 and increases apoptotic factor caspase 3. It inhibits aromatase enzyme. Reversibility inhibits function of ovary and interrupt ovarian follicular. It inhibits ovulation and induces amenorrhea and reduces menstrual blood loss. NICE, National Institute of Health and Care Excellence, documents the use of Triptogyrine Wilfordi, greater reduction in the fibroid volume and uterine size. 21 randomized trials involving 2,222 women. The average treatment duration was 3 to 6 months. Triptogyrine Wilfordi extract reduces the fibroid volume by 62.24%. It reduces the uterine size by 31.92%. It is safe and effective in the treatment of uterine fibroids. Triptogyrine Wilfordi on uterine leiomyoma. 65 women with uterine fibroids. The results of significant decrease in leiomyoma volume was detected in 60% of patients after 3 to 4 months, 70% patients after 5 to 6 months. Triptogyrine Wilfordi treatment induced an increase in mean luteinizing hormone, follicle stimulating hormone levels. Triptogyrine Wilfordi may be an effective therapeutic agent for leiomyomas with fewer side effects. Treatment shows reversibility, inhibitory effect on the ovary. It may be one of the mechanisms in decreasing the leiomyoma. A new weapon in the battle against uterine fibroids, an ester of epigalactocaine and gallic acid. Epigalactocaine gallate, the major catechin accounting for 59% of total catechins in green tea, exhibits several useful biological effects: anti-inflammatory, anti-proliferative, antioxidant effects. Epigalactocaine gallate 45%. Mechanism of action. EGCG decreases COMT enzyme and estrogenic activity, so it has anti-proliferative effect. EGCG inhibits proliferation and induces apoptosis. EGCG may be a potential anti-uterine fibroid agent acting through multiple signal transduction pathways. EGCG inhibits MMP's anti-inflammatory effect, BMP2 expression, upregulation. Number of patients 33, EGCG oral dose 800 mg per day for 4 months. Epigalactocaine gallate treatment decreases total uterine fibroid volume in patients. The treatment showed significant reduction, that is 32.6% in total uterine fibroid volume. The placebo group showed an average increase of 24.2%. Number of patients 33, dose of 800 mg for 4 months. Decrease in the symptom and severity score in patients with uterine fibroids. EGCG treatment significantly reduced the fibroid specific symptom and severity. In the placebo group, the severity score was increased by 7%. EGCG treatment increases health-related quality of life. EGCG shows promise as a safe and effective therapeutic agent without side effects for women with symptomatic uterine fibroids. Such a simple, inexpensive, and orally administered therapy can improve women's health globally. Hypovitaminosis is believed to be a major risk factor in development of fibroids. Vitamin D influence on uterine fibroid pathophysiology. Vitamin D reduces proliferation. CDK1 decreases PCNA, decreases COMT, decreases MK, I67, increases apoptosis and decreases BCL2. Vitamin D decreases TGF beta 3, decreases ECM. The uterine fibroid volume reduces. Anti-proliferative, anti-fibrinolytic, pro-apoptic effect is seen with vitamin D3. 62.5% of uterine fibroids in women are seen to be vitamin D3 deficient. Randomized control study of 108 women with uterine fibroids 10 millimeters to 50 millimeters and hypovitaminosis of vitamin D. The controlled group shows 5,000 international units of vitamin D once a week for 8 weeks, followed by maintenance therapy of 2,000 international units for a year, daily for a year. The duration was 12 months. and in the control group, they did not receive therapy. The outcome was rate of progression to extensive disease was less in the women who were given vitamin D. Vitamin D3 level increased significantly in study group. Rate of women with progression to extensive disease was significantly lower in the study group. The fibroid diameter and volume increased significantly in the control group. The treated group showed uterine fibroid growth inhibition and a lower rate of surgical or medical treatment. Supplementation therapy with vitamin D restores normal vitamin D serum levels with small burden fibroids. In these women, vitamin D supplementation seems to reduce the progression to an extensive disease and thus is beneficial, resulting in inhibition of tumor cell division, significant reduction in its size. Vitamin D3 as an effective, inexpensive, safe, non-surgical long-term treatment option for uterine fibroids. Synergy formulation for uterine fibroids, vitamin D plus EGCG. Synergy formulation address the need for treatments that bring symptom relief and reduce fibroid size without affecting fertility or causing other harms. A novel approach for uterine fibroids. Number of patients, 30 women with myomas, 15 patients, 1 tablet of 25 microgram vitamin D plus 150 milligram EGCG plus 5 milligram vitamin B6 twice a day for 4 months. 15 patients received no treatment in the control group. The total myoma volume significantly reduced by 34.7% in the treatment group, whereas it increased by 6.9% in the control group. The combined supplementation of vitamin D and EGCG seems to be an optimal approach for the management of myomas and correlated symptoms. For the first time, we showed the cooperative effectiveness as a promising and novel treatment of myomas, the European Review for Medical and Pharmacological Sciences. Triptogyrine Wilfordi plus EGCG plus vitamin D, a novel, safe, effective, non-hormonal approach for uterine fibroids. Mechanism of action of non-hormonal therapy. Uterine fibroids, triptogyrine Wilfordi decreases number and expression of progesterone estrogen receptors, decreases the aromatase enzyme. EGCG decreases COMT expression. Vitamin D3 decreases TGF-beta3 expression. Advantage of non-hormonal therapy over hormonal therapy. Hormonal therapy, action on receptors only on progesterone receptors. Non-hormonal therapy acts on progesterone and estrogen receptors. Safety profile. Serious acute drug-induced liver injury with ulipristal acetate. With non-hormonal, it is safe for liver and kidneys. Patient compliance. To be taken on 1st to 7th day of the menstrual cycle for hormonal therapy, can be taken on any day of the menstrual cycle in non-hormonal therapy. Indications and dosage. Symptomatic management of uterine fibroids, pre-operative management of uterine fibroids. The dosage 1 capsule twice daily in a minimum of 3 to 6 months. Therapy can be started from any day of the menstrual cycle. Thank you.
Dr. Shinde, had been a drug which most of the gynecologists in Delhi do not know much about this particular
ना वो patient देखा ही नहीं आज सुबह भूल गए सुधरने वाला
and I have gathered about 8 experts who are going to speak about it, but what I can say about the fibroids. Can you stop sharing, madam, your presentation?
Yes.
मैं ऊपर जा रही हूँ मैं थोड़ी देर में खाती हूँ फिर आती हूँ
Just stop sharing, ma'am.
Stop.
That is right. I can make it bigger one. What we can see about it, as far as the fibroids are concerned, you find only in 15% of cases they are symptomatic. You can see with ultrasound now available that its presence is there in quite many patients. But otherwise, if the fibroids are there, we all know that it requires a surgical management. Dr. Shinde, they want to know, all of these people want to, listening who are to you in Delhi, want to know what is your personal experience as far this salt is concerned.
I have been using it for last 2 years and it is effective. The bleeding has reduced. See, for symptomatic patients, it is very useful. And also pregnancies have been achieved after using this salt. So infertile patients can be benefited. After surgery also, many a times we know that they recur. So if we can suppress them, finish our fertility requirement, and then if required, we can do a final management.
Okay.
Because after myomectomy also, implantation problems occur. Means we don't see any fibroid, but implantation is poor post-transfer.
Question is, what I feel is about, as far as our experience as infertility and ART expert, is that, you know, there is a very limited use of these drugs. And once the ulipristal had not been there, and it has gone into this disfavor, because out of 7-8 transplants which occurred, you know, that particular drug had been taken out. As I had, posted 3 times how many people are using in city of Delhi, and we found that not many people had been using it. I will ask Dr. Jyoti Malik to make a comment on this particular thing, especially if the question has been raised in infertility. What is the use in infertility? Dr. Shinde is very happy about things, you know, whenever she feels that there is something is impinging on the uterine cavity, and this particular thing can be used before, you know, you can start stimulating your patients for ovulation induction. Dr. Shinde, I wish to tell you is that she's very popular among the Bombay celebrities, and she has a great practice as far as the infertility in IVF is concerned. I would like Dr. Jyoti Malik's comment in the beginning.
Yeah, thank you so much, Dr. Shada Jain ma'am, for involving me in this particular discussion, because this is something very, very new to me. Absolutely new to me, because I do not know anything about this salt or this product, and about the EC, EG, CG, and I mean, it is even hard to speak about the salt. The names are so difficult. I've written it here: Tritium Wilford, and then epigalactocatechin gallate. So these are very difficult, some herbal things that are there. I'm sure they might not be very, I mean, they are, since they are non-hormonal, they will not have side effects. But as far as, our experience is concerned, we are absolutely, we don't know about it. But I would like to know from Dr. Veena ma'am, that if we are giving these, then the patient, should we be starting her treatment after she has finished this course, or how do we go about it?
After 3 months of therapy.
And if suppose during the treatment she conceives, are they teratogenic, or one can sort of continue, and what is their experience?
You can continue the pregnancy.
Okay, ma'am. And what is the fibroid size reduction? That somewhere you had written 65%, so that is too good. That is very good if it does reduce the fibroid size so much, because anyhow only the unipristol, and now that we are using the mifepristone, these or otherwise we have been using GnRH analogs. So basically we had 2 things only in our armamentarium. One was GnRH analogs, and the second was SPRMs, the modulators.
Yes.
The progesterone receptor modulators. So, and if this thing is coming, if it is giving us as good results as those 2 molecules, then I think we definitely need to try it out in much more cases, because that is what I need to say, ma'am. Thank you.
Thank you.
I think I will also share with you that, you know, I have not used this particular salt at all. And whatever cases we use it, we have been using mifepristone, and especially when the people want to buy time for surgery, and, you know, we want to build them up for hemoglobin. So we use at that particular time, I use GnRH analog plus mifepristone. And that is only to buy a time a little bit. As far as infertility is concerned, I have absolutely no idea about it as an infertility expert. I will ask Vandana to make any comments because Vandana has been using this particular salt. Dr. Vandana, what is your opinion about it?
Good afternoon, ma'am. Yeah, I have used this drugs in quite a few patients. The response per se has been good. We get good amenorrhea. The symptomatic relief is very, very good. And few of the patients have conceived also. But the fibroid size documentation of reduction in size was not perceptible. So if the patient gets a symptomatic relief and she gets a pregnancy, good enough. And in patients in whom I have used who were perimenopausal, they achieved their menopause. So per se, sometimes the fibroids, they have a mind of their own and they come in spite of all the treatments we use, even with mifepristone or we use anything else. Mirena also I have used. And in that also, I have seen that the fibroids, they come spontaneously. Like a patient was given Mirena for dysfunctional uterine bleeding. She was a patient who had a known history of endometrial carcinoma in the family. And when she completed her family, I gave her Mirena. And she comes annually, she is a family member. She comes annually to India. And annually, all her checkups were being done. And I think she missed maybe 1 year. And after 2 years, when the ultrasound was done with Mirena in situ, she had a fibroid of 7 centimeters. So it seems that once they have to come, they come. Nothing can stop them. But if we get a symptomatic relief, or like you said that we have building them up for hemoglobin or so, then it's a very good drug. It's a non-hormonal. We are relieved that we are not giving hormones to the patient, and patients are also very happy using it.
Dr. Vandana, let me be very direct with you. Patient which is not interfering, which is not encroaching the uterine cavity. The uterine cavity is no way distorted. She will become pregnant whether you give the drug or you do not give the drug. See, the literature is absolutely silent about this. Whether symptomatic relief, what do you mean by symptomatic relief?
Is menorrhagia, ma'am. Yes. Menorrhagia control.
So you think with your experience, you want to advocate to everybody who's listening to you that this is a drug of choice?
Drug of choice per se, that whenever you are waiting for a definitive treatment, or maybe the patient is not willing for surgery, you can give her a trial with good counseling. That maybe your symptoms go, the fibroid stays, and if you're comfortable with it, then okay, we'll keep you under surveillance.
Okay. Let's ask Dr. Shakuntala, and then after that, Dr. Surjit. Shakuntala, what is your experience about using the medical treatment for symptomatic fibroids, especially in a patient who is looking for a child?
So, ma'am, you are asking me a very pertinent question. Thank you very much for involving me in this discussion. There are two situations. One, where the lady is infertile and waiting to get pregnant. And there is another situation where the woman is suffering from menorrhagia. She has certain other symptoms and would probably require surgery for the problem that she's suffering from. Where the woman is desiring fertility, I have not had very good results with the fibristone or mifepristone preparation. But lately, I'll give you an example. Few days back only, I had one lady who she lost a 7-week pregnancy. And when I saw her, it was like feeling like 16 to 18 weeks, size of the uterus, 16 to 18 weeks. And I have put her on mifepristone for the simple reason that she has lost this pregnancy only 1 month back. And the fibroid size which I got on ultrasound was around 8 centimeters. She is not willing for myomectomy as of now. That is the reason why I have put her on mifepristone. Otherwise, these are those ladies wherein, and we have seen this, that where it is encroaching the uterine cavity, it is pertinent to remove the fibroid, because fibroid not only encroaches the space but leads to certain changes in the endocrinal environment of the uterus. Number one. Number two, there are patients wherein we have used leuprolide, the depot preparation of leupride. The problem in these patients was that when you are planning these patients for surgery, you are not able to get a good plane. That is the problem in these patients. The plane is lost and you are very much, and the blood loss is really not, what you expect it to be. So that is one problem with the leuprolide agonist. And the moment you stop leuprolide agonist and try to downregulate and then stimulate the patient, probably these ladies will have not as good a fertility potential as you were expecting to be. With mifepristone, I have a good number of patients, around 35 patients I have used, but not where fertility was desired, ma'am. I have used it in patients where, they were symptomatic and they would have done better with surgery. In one of the patients, it was a miraculous recovery that we had. I think the moment I got this invitation as a panel expert, I have pledged that I will keep a proper record now, because this is something which has to be shared with the, we don't have huge data, but whatever data I have, in one of my patients, I had posted her for surgery at Fortis Hospital, and she had some function. She wanted to wait for 3 to 6 months. And once when she came back, her size was so much reduced that I had to postpone. I said, now you don't require surgery. You visit us every 6 monthly. But these were those patients who were not desiring fertility, ma'am.
Now, one thing is very clear that the focus for today is the different salt and not the mifepristone. I know that in a city of Delhi, this particular drug is very, very popular, and there can be situations when, you can require it to buy time. Dr. Veena Shinde, the data which you presented is your data or whether it's data given by the drug house?
It is the data given by the drug house.
See, the question is in situations where Dr. Shakuntala was talking about post-abortive patient where the size of the fibroid had been significant, will you be tempted to use the salt fibrinome in place of mifepristone, or will you take her for surgery?
If she is having symptoms, definitely. If she is asymptomatic, I will not.
Okay. I can see Dr. Surjit. Dr. Surjit, what is your comment about the medical treatment of fibroids? And are you experienced as far as this salt is concerned?
I'm very happy to hear from Dr. Jyoti Malik. She's very honest to say she even cannot pronounce the salt. Same with me. It is not easy to pronounce the salt. We just know fibrinome because it is very easy to pronounce. But I'm sorry, really, I did not use this drug. I even didn't heard of this salt earlier. I've been using FibroEase for last 2, 3, 4 years. And we have been given to 30 patients. And I'm very, very happy with the drug. There's almost 80 to 85 patients responded to that. And they have less flow, hemoglobin improved. And they're really happy with this drug. And they'll always come, just give us for another 3 months. They're demanding themselves. Even some of the patients, they have taken themselves without consulting me, even after 6 months. They had given the gap for 3 months. They started again by themselves because it is a very easy drug. And it is cheap also. Economically, it is for the patient, it's economically better for them. So I do not have that experience with that salt. But might be if she has presented so much of data that is 62 to 70% volume reduction, it is very luring drug. Anybody wants to do that non-hormonal patient, we also want to try it. And in some of the patients, but we are open to that, open for that trial. We'll try it and we'll give you back that after 3 months or 6 months, we'll give you back what kind of response do we have with our patients. But since till now, we are just doing it. FibroEase is one of my favorite drugs. This has become one of my favorite drugs. I have not used ulipistol also much. It was in earlier days, I used in only 5-6 patients, not much of the patients.
But ulipistol is out, madam. Is the FibroEase is the same salt as the fibrinome?
No.
It is not. So I think, again, please keep it to the relevance as far as this topic is concerned. Dr. Jyoti Bhaskar, what you have to say? Dr. Jyoti Bhaskar, as you all know, is the president of Delhi Gynecologist Forum East. Madam, what is your comment about this particular salt and the medical use of fibroid treatment?
Thank you so much, Madam, and Dr. Shinde. It was a pleasure hearing your talk at present and being introduced to a new salt, as everyone said. As far as the medical management of fibroids is concerned, I'm extremely conservative. I very, very rarely ever use it because I feel the total type of patients who will benefit from medical is extremely small. So those who are infertility and whose cavity is being approached, we like to do a myomectomy for those patients. The ones who are actually having menorrhagia, I personally am a good proponent of LNG-IUS, so I normally use those particular LNG-IUS for those particular patients. The ones who are around perimenopausal, they will definitely, as the menopause comes, they will stop. So personally, my experience, whether it is mifepristone or it has been ulipristal or this drug which today I'm being introduced, I have rarely ever used. So I really will not be the right person to talk. But one thing I was, when you were talking about the vitamin D that you was using, because nowadays we all are really giving vitamin D to nearly all our patients.
Yes.
Do you think that the overall incidence of fibroid is going to reduce in our women if we are supplementing them all with vitamin D? Because this drug has been talking a lot about vitamin D. So where do you feel, does it have a prophylactic role in prevention of fibroids?
Dr. Jyoti Bhaskar, I will just tell you, vitamin D is implicated with everything. So it is always good, in case you find things are expensive, give one shot of 27 rupees vitamin D to your patients. If she is going for hysterectomy or she is going for any surgery, you can take it from me that you can use this particular thing. They will implicate it with anything. Because, even if you treat her remains, vitamin D remains the same. Vitamin D will remains the same. I want to ask Dr. Sahai is here. Dr. Asha Sahai, Dr. Nirupma, in case you want to make a comment, because they have used it in one or two patients. What is Dr. Asha Sahai, what is your view about it for a medical management of fibroids? Madam, you unmute yourself, please, madam. Madam, unmute yourself.
Yes, madam. Good afternoon. I have only used it in 4-5 patients who were perimenopausal. I have not used them in patients who had submucous fibroids or coming for infertility or younger age group. So those patients who were coming to me with menorrhagia and were not willing to go in for surgery at an early time. So in them, when they came with menorrhagia, we start with anesmic acid, give them for 4-5 days, start with Fibrinome, and tell them that you continue the Fibrinome for 1 month, 2 months, 3 months. And if it gives you, because with vitamin D and the green tea extract and all that, it gives them sometimes a feeling of well-being also. So, and the general body pain is there, backaches and things like that. They will automatically improve because of with vitamin D3. Plus, if the menorrhagia goes, the general hemoglobin increases. So I have only used in 4-5 patients who were perimenopausal age. 3 months after that, gave a break for 2-3 months, repeated the ultrasound. But beforehand only I told them it is not necessary that there will be a significant reduction in the size of fibroids. So don't come with that mindset. So in case if the menorrhagia goes off and maybe after 6-7 months, you are not getting your periods back, already maybe spontaneously you have passed into menopause, that is your good luck. If you come back again and the bleeding starts again, then we counsel them for surgery. Because then again we will be giving for 3 months, then again for 6 months, and then you're back to square. So sometime in the duration, you have to make up your mind for the surgery. So that is my experience with perimenopausal patients. And that has been good for 3-4 patients.
But Dr. Asha, I would just like to ask you, in the perimenopausal, how do you define it's a fibroid or it's the hormonal issue which is leading to bleeding?
No, they are coming with the ultrasound, no, Dr. Jyoti?
Yeah, but there may be fibroid in so many of them. It's not.
They are fibroids. They are having they may be fibroids. And there may be other reasons also. With the UV also, with the...
So would you say that this drug is good for AUB and not so much for fibroids?
No, maybe sometimes if the endometrial thickness is okay, and it is, yes, if we are looking at the endometrial thickness, which is 4 millimeter, 5 millimeter, and only the fibroid size is more, and the menorrhagia is there. So I don't think there is a harm in trying the drug and telling them.
Endometrial thickness of 4 to 5 millimeter will never give rise to menorrhagia.
It will not give rise to
yes. Will never give rise to menorrhagia.
So this gets a little confusing. What are we doing?
The size of uterus is more, endometrial surface is more, endometrial thickening is there. Then we can think of AUB. Sometimes it is not easy to differentiate between two. But commonly what we think in our mind is endometrial thickening, complete endometrial surface, what is the size of the uterus, it is due to fibroid, it's a fibroids are very small in size and the still uterus size is more. Then we think of something like
fibroid is coming to the
can we hear from Dr. Anita Agarwal? Anita Agarwal, another gynecologist with good practice. What is your experience about this salt? For a medical management, for infertility cases.
Thank you, ma'am, for involving me in this discussion. And this topic is very close to my heart. I am listening, and Dr. Shinde's lecture was totally very, informative. And as far as this compound, very difficult to pronounce, tryptophan Wilfordi, plus vitamin D and all. I have used this product in 5-7 patients, but that too, in those patients, they are premenopausal, not desiring fertility. Response as far as symptoms are concerned is good. Bleeding is less, and in few patients, size of the fibroid has also diminished. Like small fibroids, less than 5 centimeter, they are slightly touching the endometrial cavity or slightly protruding. Those are patients, they really help by this. And they are very happy. I have given for 3 months, 1 month gap, and again for 3 months. Few patients, it totally disappeared, but they are only smaller, less than 5, not with bigger one. As far as fertility is concerned, normally there are so many other factors also, and fibroids are never single. And we need to really find out the cause, what type of fibroid. Is it really the submucous type, which is very likely to cause infertility or impaired, which impairs implantation. So,
Dr. Anita Agarwal, we are very happy with your inputs that you feel there is a place of these medical management as far as the perimenopausal fibroids are concerned. And sometime you may find you can avoid surgery altogether. I think, more and more people are going to use it, then only people will know about it. But majority of the experts are silent as far as their role in infertility is concerned, except Vandana, which says that she agrees with Dr. Veena Shinde as that, some symptomatic patients of infertility can be also taken up. They will conceive on their own. It is not this particular salt has done anything. Because in case if there is nothing interfering in the uterine cavity, she will conceive otherwise also. Let's hear from Dr. Nirupma Goyal. Nirupma Goyal, what do you have to say about as far as this salt is concerned? You also use this particular salt.
Thank you, ma'am, for giving me this opportunity. Ma'am, I have used these salts in many of my patients, but none of them turned up with permanent relief. There was only relief in bleeding, in pain, in the form that they feel better, and there was a sense of well-being. So as Dr. Surjit said, they forced me to give it again and again. And in 3-4 of my patients, I repeated it again. 3 months, 1 month gap, again 3 months, again 1 month gap, 9 months. But ultimately, I came to the conclusion that size reduction was very poor and there was short-term relief. So what I feel ki these drugs are good for short-term relief, operative preparation. Otherwise, as a permanent therapy, I am doubtful.
Dr. Chandranatha, you want to say something? You also use this particular salt?
Yes, ma'am. Thank you for involving me, and nice, deliberations by Dr. Madam Shinde. I have used it actually. I heard it in one of the, in some conferences. It was introduced long back, 5-6 years, but then it was not promoted. So, maximum I have, used in the patients who are from 30 to 40 years of age, not infertility group of patients, and those who are, adamant not to have surgery. So at that time, the effect is there because it has got anti-inflammatory effect also, and it has got a high antioxidant activity also. So the pains and all, those prostaglandin pains and all during periods of this when fibroids are there, so they are taken care of. Even the size is also reduced. And, the much, pressure was given by Dr. Usha Vaid. She uses it outright. Yesterday only she talked to me. So there was a good result of her patients. And even I have also seen that there is 30 to 40% reduction in the size of the these fibroids. And basically these fibroids are intramural and a little bit of maybe, entering into the endometrial cavity. And there was one patient, she was 45 years, severe menorrhagia, a big one, 8 centimeter. But I was surprised. At that time, these drugs were not there. I gave her Danazol because she said, "Jo bhi marzi ho jaye, surgery nahi hone." And madam, मैंने तो उसको, prescribed for 3 months. And that lady, because of amenorrhea, she never came. And after 1 year, the fibroid was not there.
Let's not talk about. See, we are confusing
and now,
people.
No, because this Fibrinom, it has got that tripterygium, Wilfordil root extract, green tea extract, and vitamin D. So I think all these help in the, little bit hormonal.
What is your advocacy, ma'am? What is your advocacy?
No,
because
think,
100 people are listening to you.
No, I think we should use it. It has got a good role. We must use it as a medical management.
You're still using?
We are coming to final sum up. As far as you ask me personally, I feel there is no place of medical management as far as the infertility is concerned. I feel for a patient requiring surgery, and she's reluctant for a surgery, you can definitely give it a try. It's a good luck that she will do it. I fail to believe that there is a drug like this that Dr. Veena Shinde and you people say that a 65% decrease in the size is there. I think the Nobel Prize one should get. So one thing is very clear, we have not followed up. I asked the company people, they said during the corona times when the surgery people were reluctant to get surgery done, this particular drug has been promoted and quite a few people, including Dr. Veena Shinde, found that the symptomatic relief has been there. I fail to believe myself, there are many infertility experts there, that it promotes infertility. No, it cannot do it. It cannot do it. Yes, if she's buying time for this thing, it can definitely give us symptomatic relief. And in case if the size can decrease for 60-65%, I think it's absolutely a great salt and worth trying it. Because this particular salt is mainly antioxidants, and you find that there will not be problems like unipristol, which we have had earlier. So I will like Dr. Veena Shinde finally to make comment after listening to 8-9 people on the spread. In every corner of Delhi, people are there. What they want to listen to you, because you are from outside, you're a very popular gynecologist as far as Bombay is concerned. What is your final comment on this?
It is very good for symptomatic treatment. The size may or may not reduce after 6 months. The patient can conceive if she is taking treatment for infertility during the medical management. If she conceives, she doesn't need to discontinue her pregnancy. And there are no side effects like unipristol. So we can definitely use it. Surgery always remains the final management, irrespective of the medical management. In case of necessity, if patient is bleeding heavily, patient has malignancy, there is no use of any medical management.
Meenakshi Sharma, you want to say something? Meenakshi?
Ma'am, yes, ma'am. Can we take some questions which are there in the chat box?
Yes. I think I've taken Rita Malik's questions, infertility related questions. Yes, Dr.
Yes, ma'am, there was one question also. Ma'am, there was one question that it's an herbal preparation, and can the allopathic doctors like us, can we use it medico-legally for the treatment of fibroids?
See, as far as the Supreme Court orders are concerned, any herbal preparations should not be used by the allopathic doctors. As for the Supreme Court order is concerned, if we are sure about it, this is a herbal preparation, it cannot be used by allopathic doctors. See, I have nothing to, as far as this particular salt is concerned, I have come in a very impartial way to do a moderation for this particular salt. And I want to have, that's why I in the last 5, 15, 20 days, I've circulated in 9 forums, that is reaching to 3,000 people. Anybody has used this particular salt, I want to include them in a panel, and everybody who has said yes, they're all there in the panel. And out of this, 50% have said they have never used this particular salt. So Veena is trying to tell you that it is you have to decide if it's a herbal preparation, whether you want to use it as an allopathic doctor or not to use it. Any other question?
There was a question regarding that. Do we need to do the LFTs and a complete workup in the patient, and during the monitoring should we be using the liver function test to monitor such patients, or any other toxicity which has been reported on this treatment?
See, as far as the medical management is concerned, Ulipristal history is not far away. 8% people in UK had a liver failure, they had transplant, and majority of them have died, except 2 people have not died, 6 people have died in spite of the liver transplant. So I feel anything which you're using, especially herbal, especially Ayurvedic, must have a baseline liver function test and a kidney function test done. You should never use it without this. I'm sure Dr. Shinde will also speak the same.
Definitely, madam. Always kidney function test for Ayurvedic preparations.
And what was the maximum duration of the treatment which has been advocated for such patients?
6 months.
6 months.
Not beyond that.
Okay.
See, Dr. Renu Chawla, you want to speak something? Dr. Renu Chawla?
She's not there.
Okay, she's not there. So I think it had been absolutely wonderful to know about this particular new salt, and it's all in front of you. It's a herbal preparation, and you've heard so many people from the city of Delhi who have used it in 1 or 2 or 3 patients, and they have given their viewpoints about things. And it is rest depends upon you. How are you going to take it? And we are very thankful to Dr. Veena Shinde to come and speak about this new salt and share her own experience here. She is a respected doctor in Bombay, so we will definitely say she is respected in Bombay. She will be respected in Delhi also. So with these words, we will go ahead, and this is what the conclusion is, that gynecologists who are listening, is an herbal preparation. Whether you wish to do it or not, you definitely ask them. And as far as Supreme Court is concerned, it says that the doctor should not use herbal preparations and things like that. It is for you to do it. Secondly, herbal preparation and tea वगैरह ही चीज बात होंगी. And I think as far as the infertility is concerned, it is very happy situation that, a patient who is infertile, has menorrhagia, you give her a time, this thing, and this does not interfere with any ovulation induction agents. You can take this particular drug and you can induce that particular patient and she can conceive. And according to Madam also, once she conceives on this particular drug, there is no need for termination. There's no need for termination. This is what Dr. Shinde has also said, and this is what Dr. Vandana also has said. She has never said how many numbers of patients had conceived, but she says that patient can conceive and can have all the treatment as far as this particular treatment is concerned. Otherwise, everybody has said to buy time, whether majority of them have said to buy time, patient finally, when she makes up her mind, you can definitely use it. And if she's lucky to get 60 to 75% reduction in the size, I think one thing. अगर 10 में से 2 लोग भी और 3 लोग भी को भी फायदा हो गया, तो मैं सोचती कि बड़ा फायदा होगा. बिल्कुल. Last minute comment by you, Dr. Jyoti Bhaskar.
And definitely after hearing the deliberations today, I would also like to use it in those small select patients who are going to be awaiting surgery and who are sick. So definitely we'll try, and hopefully 3 months later, we'll have another meeting to see how we all are fared with this.
So they had been at 10 experts, right from Bombay till here, that they definitely shared very honestly what is their, take on this particular thing. And rest of you have to decide on your own. Thank you very much. Thank you very much, Dr. Shinde.
Thank you.
Thank you so much. Thank you, Dr. Vinay. Thank you so much.
वंदना, तुम लोगों ने छोड़ी क्यों फिर यूज करके? या डॉक्टर चंद्रलता ने छोड़ी क्यों?
छोड़ी नहीं, ये तो अभी डॉक्टर साहब कोविड के टाइम पे उन्होंने प्रमोट किया है.
छोड़ी अभी भी
कोविड के टाइम ही प्रमोट हुआ है.
छोड़ी नहीं, अभी भी यूज कर रहे हो आप?
हाँ, प्रॉब्लम ये है कि मैंने इनफर्टिलिटी में कभी नहीं करी, क्योंकि इनफर्टिलिटी में थोड़ा लगता है ना, प्रॉब्लम ना हो जाए, कुछ ना हो जाए.
डॉक्टर सुजीत, में छोड़ी नहीं होती है कई बार, जैसे आप बोल रहे हैं ना 3 months के लिए दिया पेशेंट को, फिर वो लौट के नहीं आएगा, उसको बेनिफिट है वो खाए जा रहा होता है, ये प्रॉब्लम हो जाती है।
नहीं, हम तो अभी भी देते हैं ना, फाइब्रोइड्स अभी भी आते तो देते हैं।
इनफर्टिलिटी में डॉक्टर सुरजीत पता है क्या एक बेनिफिट है? पेशेंट अभी जैसे सपोज देयर आर सम रीजन शी डजंट वांट टू कंसीव, देयर इज अ फाइब्रॉइड, है ना, एंड शी इज मेंटली स्ट्रेस फ्री, मेरे को इस टाइम अभी कंसीव भी नहीं करना, फाइब्रॉइड मेरा हो सकता है कम हो जाए, सिम्पटोमेटिकली रीअश्योर है कि बेनिफिट हो जाएगा, they come back with pregnancy maybe because of stress relief as well. It could be, that's what I'm thinking.
वो तो समझ में आ गया, ये वाली बात तो समझ में आ गई है, बट अभी भी कर रहे हो ना यूज आप लोग, अभी भी कर रहे हो।
Yes.
Dr. Veena Shinde, everybody wants to hear from you. आपके पेन में ये कैसे आता है, किन पेशेंट को देना चाहिए? Let's hear from you.
Patients who don't want surgery, patients who want to conceive, basically abnormal uterine bleeding. Not so much for large fibroids.
Okay.
Large fibroids definitely need surgery. We cannot play with the life of patients.
आप तो elite को देखते हो डॉक्टर साहब।
हाँ, elite को ही देखते हैं, तो elite को ज्यादा हमको ख्याल रखना पड़ता है. They are well read, so we have to be more careful with them.
चलिए, so thank you very much.
एक क्वेश्चन पूछ सकते हैं?
हाँ जी बोलिए।
मैम, एक पेशेंट है 33 years old, अभी उसकी कॉल ही आ रही थी, उसका 10 सेंटीमीटर का फाइब्रॉइड है, मैक्सिमम सबसिरोजल एंड इंट्राम्यूरल, उसको सर्जरी बिल्कुल नहीं चाहिए, फैमिली कंप्लीट, तो उसको क्या?
उसको सिम्टम्स ही नहीं तो छोड़ दो ना।
नहीं, ब्लीडिंग है ना, हैवी नहीं हैवी पीरियड, हैवी पीरियड,
मीफेप्रिस्टोन डाल दो,
कुछ उसको देना नहीं,
डालो ना।
यस,
मिफेप्रिस्टीन पे डालो।
हाँ, मैं तो वही
फाइब्रोइड की टैगलाइन ये है कि इफ इट डजंट ट्रबल यू डोंट ट्रबल द फाइब्रोइड।
साहब, आप में गट्स होने चाहिए, पेशेंट रिक्वायर्स सर्जरी, पेशेंट रिक्वायर्स सर्जरी, पेशेंट रिक्वायर्स सर्जरी, दैट्स इट।
बड़े
गट्स होने चाहिए, क्योंकि मेडिकल ट्रीटमेंट से कुछ भी हो जाएगा, अगर आपने दवाई लिख दी है तो सारा ब्लेम आपको जाएगा।
चल हो गया, सार्कोमा हो गया तो क्या करेंगे?
पेशेंट को मॉनिटरिंग में रहेगा ही, सार्कोमा अब तो भूलता नहीं है। एट वन टाइम तो हम लोग बड़ा बोल्डली कहते थे ये वाली बात कि कैंसर नहीं होने वाला, अब तो हम नहीं कहते ये वाली बात इतनी बोल्डली, हम कहते हैं ऑल्दो इट इज रेयर यू हैव टू बी अंडर मॉनिटरिंग। अभी तो जब मैं पढ़ रही थी सार्कोमा को, तो उसमें ये भी लिखा था कि सडनली सार्कोमा जो बिनाइन ऑलरेडी उसमें नहीं होता है, इट इज जो नया फाइब्रॉइड बनता है वो सार्कोमेटस कैंसरस फाइब्रॉइड है, तो बेसिकली ऑलरेडी प्रेजेंट है, 10 साल से प्रेजेंट है, उनमें चांसेस कम है कि वो सार्कोमा में कन्वर्ट हो जाए। इट इज ओनली कि जो नया फाइब्रॉइड आया है that looks like a tumor, that looks like a fibroid, that has come with the sarcomatous changes already. So normally we cannot say that benign tumors presenting for last 15 years now it has changed into malignancy. Abhi bhi
there is a rapid increase in the size
rapid
of
increase in size, yes, rapid increase in size. That is, and patient has to be under monitoring whatever drug she is taking, whatever drug. हम तो पेशेंट को जब देते हैं ऐसी दवाइयां, जब हम लोग कभी यूज करने की कोशिश करते हैं, भाई तो गिव वन थिंग, इट इज नॉट एन एलोपैथिक ड्रग, देन पेशेंट शुड आल्सो नो इट, although we would try to we will give you a trial only, it is not allopathic, we are not supposed to use it. तो मैं उनको बता देती हूँ ये वाली बात कि कल को ये नहीं कहें कि आपने हमें बताया नहीं कौन सी ड्रग है, बट ये है कि उनको पता जरूर होना चाहिए कि इट इज नॉट एलोपैथिक ड्रग, नॉर्मली वी डू नॉट यूज इट, बट आई एम केसिंग, वो तो बहुत खुश हो जाते हैं, उनको कोई एलोपैथिक ड्रग नहीं है तो बहुत खुश हो जाते हैं।
Absolutely right.
The presentation which has been done which by Dr. Shinde provided by the drug house nowhere mentions infertility. So please, whosoever is hearing me should not use in patients who are infertile. Infertility should be kept on the side, and yours they are symptomatic patients, so you're treating them for symptoms and not for infertility. So my request to everybody who's listening me that they should not use these particular drugs, especially the new drugs in infertile patient of yours.
I don't use. Infertility.
So thank you, Dr. Shinde. This will go on endlessly. Thank you so much.
Thank you.
Namaskar.
Thank you. लेकिन बड़ा ल्योरिंग लेक्चर था, 62% पीछे हो जाए, मजा आया।
100 people joined it, madam.
हाँ